I just want to set the scene first, and we're going to go over to the screen over there. Labor's been arguing that it's been addressing years of underspend of neglect in the health sector. So we compared last 6 years of National's budgets, and they were up by 18% over that 6 years. And then we compare it with the last 6 years of Labor, and there was a 45% increase over that 6 years. That sounds massive, Dr. Verrill, but does it actually include COVID?
It'll include, some of it will include COVID, some of that was COVID funding, but there's also been substantial increases elsewhere, for example in the health capital envelope and in the Pharmac funding, which has increased by 41%.
So if you took COVID out of there, would that just like cancel out all the increases?
No, absolutely would not. There's been substantial increases.
Do you think it's been value for money, that 45% increase?
Yes, I do. It's meant that we've been able to grow our staff. We've increased the number of doctors in our health system by 2,000. We've increased the number of nurses in our system by 5,000 over the time we've been in government. We've been able to reverse the trend of stagnating investment in our buildings. We've approved over 175 new medicines, and really importantly, we've developed a new primary mental health system as well. So we've also grown what we're doing.
So you think it's value for money. Dr. Leti, I mean, National's track record, they say that they've been way outspending you, that you underspent for National, underspent for years. How do you respond to that?
So whether there's new COVID money in there or not, I think when there's new money in health, that's got to be a good thing. And, and my view is, I think actually the Labor government has put more money into health.
Great.
But the question I've got is, though, more money, more bureaucracy, worse outcomes. It's joining those together. None of us mind spending more money in health, quite the opposite. But then we need the outcomes to go with it as well.
Right, OK. So let's talk outcomes, OK? Health targets, your policy this week, you set health targets. One of them is you want 95% of patients to spend less than 6 hours in an emergency department. I spoke to emergency doctors this week. They say 80% is the realistic term. Surely they would know.
The target was derived with the Australasian College of Emergency Medicine. They helped us form it when we formed it back in 2008.
Are you sure they put out a press release this week saying you didn't consult them?
They put out a press release saying targets save lives.
And that you didn't consult them?
The original target was consulted with the Australasian College of Emergency Medicine, and it is the original target. It's the one we've had for decades, actually.
Right, so you didn't update it? You didn't go back to them and say, is this still realistic?
Oh, I'm in regular contact with emergency doctors, and we'll stand by that figure, and we'll report it regularly as well.
Why would their target now be 80% and yours is 95%? They're the people on the front line who would know about it.
Yeah, they'd actually raised that a few months ago, so it's not new that they might want to change the targets, but we consulted with them, and they helped form the original target, and we've decided to carry that forward, amongst other things.
Is that realistic, though? Because we just don't have the staff.
Well, amongst other things, so that we can see continuity over time. If you change the goalposts, you can't compare to how you were doing before and after, actually.
What's your response to that?
I don't have an ideological problem with targets. They have a role. I've set a smoke-free target. We're making excellent progress towards that. I've set a target that wait lists for non-orthopaedic surgery, no one should be waiting more than a year by the end of the year. We're going to hit that goal, and that's excellent. But the problem with targets, and I know because I worked in a hospital under the last National government, is unless you back that up with resourcing, all you're doing is blaming the clinicians when they can't hit the goal. If you don't provide them with staff, with space and with resources. That's why it all comes back to funding.
So I did talk to the Association of Salaried Medical Specialists this week, and they feel like the targets, Dr. Leti, are, in their words, a stick to beat specialists with.
No, not at all. It's a direction of travel that brings attention, that brings resources, and sort of here's the difference between us. As I understand it, the Minister has said targets will not be at the forefront of her health policy. I will have targets at the forefront of my health policy. They bring attention, they bring resources, they bring a direction of travel, and I agree with those doctors.
You don't have a track record of bringing the resources, and you have a $2.1 billion hole in your tax policy.
I agree with clinicians who say targets save lives, so I back clinicians, actually.
How are you going to fund the staffing and have the resources to get to those targets?
So our fiscal plan, which we'll announce shortly, will detail exactly what the health manifesto is going to cost up, and I'm looking forward to bringing that forward, actually.
OK, well, we are all looking forward to that. Just lastly on targets, Dr. Verrill, I mean, the latest sort of stats from Te Whatu orders show that this particular, say, if we take the 95% of patients who should spend less than 6 hours, that's Dr. Leti's target, but we're only getting 72% of patients are spending less than 6 hours, and that's getting worse. And that's on your watch.
Indeed, we have had problems post-COVID with people waiting too long for care. But there are a number of outcomes that we're doing very well on. As I said, the surgical wait lists are coming down. We have our smoking rate reducing. Particularly important, our suicide rate is down by 21%. And if you were to say what is the most important measure in the health system, over the last 3 years, we've had some of the lowest excess mortality in the world. So on the things that matter, we are doing well. I agree, post-COVID, people are waiting too long for care, and it's really important we drive that down.
Let's go to the push by you to get more people to go to GPs first, to take the pressure off the emergency departments. But some clinics are closing. It's taking weeks in some areas to get an appointment. I don't see a policy from you to help bolster the GPs.
We do want to make sure that in the next term of government, a lot of our investment is in general practice, and we want to make sure we're bringing care closer to people's homes and that we're investing in those places in the community.
But with such a record health spend, we haven't seen anything in terms of increasing that sort of substantially, that funding for GP
I
clinics.
agree that will be a priority
right,
for
so
the
next term. Has that been a failure
term.
of Labor's tenure so far?
No, during the COVID response, we used other instruments to fund general practice, and now we need to transition to increasing the baseline, as we have done. Highest ever increase to general practice funding this year in a long time. But may I just add, we've done a number of things on the general practice workforce to really strengthen that in the short term. General practice trainees are paid the same as hospital specialist trainees now. We're making sure that general practices are paid to fill long vacancies, particularly if they're rural. A number of things to strengthen the workforce.
So you've done those, and you're saying that you would address that should you get re-elected?
Yes.
Okay. What's your policy regarding, bolstering the GPs? Because this is the front line that should be addressing. That you should be addressing.
So I am a GP, so I understand that, and they speak with me frequently. Look, fundamentally, we need more GPs. We need to look at how we retain those that we have, because there's significant remuneration issues for general practice at the moment as well. So we need to look at retention. We also need to look at scope extension, how there are others who can provide primary care and come to the primary care interface and do more. I do agree with the minister. I do agree with the minister. She said that she'd equivalated the training funding for general practice trainees along with registrars. That was a good idea.
So all this sounds great, but if I'm trying to see a doctor in Auckland at the moment, it's going to take me weeks. I might have to end up going to a 24/7 medical centre. That's not acceptable. So what funding are you going to put in there to get GPs for me to go see them straight away? As soon as
I bring forward my manifesto. You'll see other things, Simon, that I think you'll be very pleased with.
So we've got to wait. We've still got to wait for the funding. You've still got to wait for your promises.
You'll wait for the rest of our manifesto to be released.
We've just got 1 month to go, and we need clarity on the funding. You're promising that?
Yes, I am. Yeah, our fiscal plan will explain how we're going to fund what we're going to deliver in the manifesto.
Okay, well let's talk about. You've both announced doctor training programs, so I'm not going to talk about that. But training those doctors isn't going to alleviate the urgent shortage of specialists at the moment. At the moment, we've got specialists striking, and 40%, says the union, are looking to reduce their hours in the public system. Is it possible, it's soon going to be impossible, to see a specialist through the public health system?
Absolutely not. I was a hospital specialist and I know just how much value they provide in our health system. The negotiations between the union and Te Whatuora continue. I hope both parties are very close to an agreement there. Labor's committed to make sure that we rapidly fill 300 specialist vacancies in the health system, because I think one of the biggest things for our specialists is the fact that when they're staffing rosters without enough people, that's really challenging. The main way
that's why they're striking,
the main way we have to do that is through immigration in the short term. Training will take too long otherwise.
So the answer is
and we've had over 1,100 international doctors come to New Zealand just in the last year, which is the highest in the duration the Medical Council.
Here's a stat which is a bit damning, okay? The number of patients left waiting for 4 months before their first appointment has almost doubled in the major centres in the past year.
Yeah, so we have to bring those wait lists down, and we have a plan for doing that, but it involves stepping through it. The first list that we prioritised was the non-orthopaedic surgery. We are on track to clear that. Then we have to do the orthopaedics and start doing the first specialist
Okay, so you've got those goals, but you acknowledge that it's just not a great
Absolutely,
situation.
it is not acceptable. And as I've said, post-COVID, people have waited too long for care. We have to step through in an orderly way, getting those lists down, and we are.
So the Minister acknowledges that it's not good enough for Shane Reti, but how could you possibly fix that? Or do we have to wait for the fiscal plan again?
So I accept that COVID has been a contributor, of course, but I think if we want to talk about wait lists and wait times, also look at the 2 years, 18, 19, before COVID even arrived, and what were the wait lists doing? That they were getting worse, OK? So COVID a contributor, but even before COVID, they weren't doing so well. I think the solutions here are several fault. I agree. The short-term solution to workforce is immigrations.
Okay, so you agree on that.
I also think retention, which is a feature of wages and salary, and terms and conditions. So workforce. We would say targets also focus attention, and then funding, redistributing that funding back to the front line across that spectrum is where the solutions for waitlist.
So it's money. You know, we're going to need money to pay these people just to do their jobs and not have and get more people in. So. Again, it's about money. You still can't tell us.
It's about workforce.
So the problem Dr. Reti has is his party is not able to give a clear commitment to increasing health funding in line with inflation, which is where we get the money in order to pay the annual salary rounds of all of our
Okay, well
staff.
let's get that one sorted. Will you increase health funding in line with inflation? Because it seems to be your leader seems to be going flip-flopping on this one.
I will increase health funding to the front line in line with inflation.
To the front line?
At least in line with inflation.
Is laboratory the front line? Is radiology the front line? All of those essential services?
Front line are those who get really close to the patient and have a patient interface.
Someone who reads an X-ray, is that the front line? Because it's critical.
I think that's the important part. So we will increase.
Do you have a problem?
Inflation.
Do you have a problem there, Dr. Reti, identifying what is front line and what is back room? Because that seems to be the national policy. Not necessarily?
No, because also what you've seen the government say is that they're going to reduce backline staff as well as part of reprioritisation. So we all have that same discussion around what is backline. What I would say to you is backline, in my view, for example, is the PR consultants that we have, or communications people across the sector, who I think are too many. I consider them backline.
So Te Whatu Ora says there are 154 communications consultants, right? Te Whatu Ora has... What's the size of the Te Whatu Ora workforce?
More than 62,000.
OK, so is that not justified?
No,
I mean, they're doing public service campaigns like immunisation.
That is too many, and then add those from the Ministry of Health as well. In my view, that is too many. I need real docs, not spin docs.
Right,
actually.
so in terms of, if you're going to take Dr. Reti's position, you know, too much backroom stuff.
We've saved over $119 million on sensible backroom savings. Things like the fact we had 20 different insurance policies under the DHB program. But you cannot... what's going on here is the National Party are trying to leave themselves wiggle room about deciding which services they will fund and which they won't. When they've got a $2.1 billion hole in their costings, what that means is... in their tax costings. What that means is they'll have to find these savings in the health system. And that's what... and that means that there will be frontline service cuts.
OK. You're saying there will be frontline service cuts.
Under National, there will be.
That's right. It's kind of interesting blaming the DHBs. You were in charge of the DHBs. It's not like they're a separate entity at arm's length. They had annual plans that you held them to account for or did not. So there's always that discussion of, under DHBs, but you were in charge of them for 5 years, for goodness sake.
That's historical. Will there be cuts to frontline services under National?
No, we will increase frontline services.
All right, let's just move on from that. So elective surgery wait times. I've got two examples that have been given to me this week. One, a 9 to 12-month wait in a major centre for a simple children's grommet operation. Secondly, a patient who has elected to pay $30,000 out of their own pocket, not insurance, to get a hip replacement because they couldn't wait for the public system. What does that say about our hospitals?
It says that we've had a backlog that really did blow out over COVID, and it absolutely needs to come down. When I became Minister at the beginning of the year, I identified everyone we needed to have operated on to meet that goal of no one waiting for non-orthopaedic surgery by the end of the year. There were 50,000 people we needed to operate on. We're now down to 9,300. We're going to hit the target by the end of the year. We're going to clear
you say there's work underway. Do you accept that? Do you accept that these wait lists are coming down?
I see some changes. I see some plateauing at the moment, which is really satisfying. Very unfortunate for the people you're describing. You know, they'll be in pain, children with grommets. Imagine what that does to their education and their hearing. It's the long-term consequences of this. This is not trivial.
No, it's not trivial. There's one other stat on this that I want to get out there. 2/3 of our elective operations in New Zealand are now done in private hospitals, and that's public-funded operations being done in private hospitals. So we just don't have the infrastructure or the staff.
We need to grow our public health system. We have 100 beds and 8 theatres opening on the North Shore shortly, a large super clinic in Manukau as well that we're redeveloping. However, I am not prepared to wait and leave those people with those conditions on the wait list. We do have to outsource to bring it down and then get to our baseline and be able to more sustainably operate.
Right, so you're saying, are you giving a commitment to actually bring it back more in-house?
Absolutely.
Okay.
That's right, but we have to catch up. We can't leave those people waiting.
Okay.
And we'll use the private sector to do the catch-up.
All right, so is it okay to use the private sector like that to get...
It is, I agree. That's the right direction to travel.
Okay, all right.
We need to build public capacity, but in the short term, the only way we're going to deal to those waiting lists is to collaborate.
And once you've dealt with the waiting list, will you bring it back in-house, or are you happy to be more to be?
Oh, the intention has to be for that capacity to be in the public sector.
Okay.
That has to be the end.
All right, so you both agree on that. Let's talk health equity. So we know the life expectancy stats, Māori die earlier. Dr. Reti, you want to abolish Te Aka Whai Order, the Māori Health Authority. How would that increase the life expectancy of Māori?
So what that will do is that will let us bring more focus, more attention, more structure, but more importantly, more decision-making closer to the home and closer to the hapu.
Right.
Because unfortunately what the reforms have done is they've centralised decision-making, they've centralised funding, and that includes for the Māori Health Authority as well. All the Māori health provider contracts, all $500 million of them, are now held in Wellington by the Māori Health Authority.
Right.
We think that along with other parts of the health reforms, that decision-making, that funding, should move as close to the home and as close to the hapu as possible.
All right, so you'd say that would increase Māori health life expectancy. When you were asked recently about what one of the major barriers is to health outcomes, you did say the lack of embodiment of te tiriti or waitangi. So how is that? We've just been spent all this time talking about the lack of workforce and facilities. How is that the major barrier to health in New Zealand?
It is a major barrier to addressing the issue of health equity. When some people are dying, Māori are dying 7 years earlier, I think that is an existential challenge for our health system. So what the Te Aka Whai Order is it is giving an independent voice for Māori. That's the main difference. It's independent of the Ministry of Health.
So how would the Māori Health Authority, how's Te Aka Whai Order going to increase that life expectancy?
Because it holds everyone else in the system to account for outcomes for Māori. It asks Te Whatuora, what are you doing about cancer outcomes for Māori?
All right.
Also, I just reject Dr. Reti's idea that it is centralisation. Part of that process is having iwi Māori partnership boards at the local level, making decisions about primary and community care.
All right, look, I've run out of time. The health has got so many facets, so many topics. Thank you so much for your time today, Dr. Reti and Dr. Verrill.